and a general surgeon with interest in upper GI and bariatric surgery based at University Hospital Lewisham. I am your moderator today as we continue the series of Royal College of Surgeons of Edinburgh Regional Surgical Advisors webinar for undergraduates. We would like to thank the college for the opportunity to be able to present to you today. There are over 40 RSAs, or Regional Surgical Advisors. We are consultants and fellow of the college. And we provide advice and support at a local level in the UK. You might have met us in your local teaching events or careers events. If you haven't and want to get in touch, please look at the college website and you will be able to find the RSA in your region. Today's topic is hernia, anatomy and pathophysiology with principles of management. And we have today Mr. Colin Weir, who's giving us the presentation. Colin is a general and vascular surgeon based at Southern Health and Social Care Trust in Northern Ireland. He's an honorary clinical lecturer for Queen's University Belfast. He has previously been a Director of Medical Education, a member of the National Steering Group of ATLS, and has been a course director at ATLS instructors, and basic surgical skills. Before starting the presentation, may I remind you that you can use the Zoom button with the Q&A facility to post questions during the talk, and then we will try to answer as many of your questions at the end. You can also vote with a thumbs up as to which questions you would like most answered. So over to you, Colin.
Thanks, Cynthia. So hi, everybody, and welcome to this short talk on the principles of hernia anatomy and pathophysiology, and basically basic principles of management. So today we're not going to cover in a lot of detail individual hernia or hernia sites, and I think really what I wanted to do was to give you a flavour of hernia at several sites, but basically in the anterior abdomen, which we call ventral hernia, and in the groin area. Again, there will be other webinars in future, I'm sure, that will cover more specifically, and I'm sure in particular, groin hernia in particular, as it's a very common surgical condition and would benefit from a further, more in-detailed webinar. So as it says on the screen there, we're going to discuss briefly, and not, you'll be glad to hear in a lot of detail anatomy, but maybe what's relevant to you and your learning, the main sites, the types and the basics of the causes of hernia, some of the clinical features that would be important to you, and the principles of management and treatment. So what is a hernia? Well, we all need a definition of a hernia, I suppose, and here's one. I'm sure you'll find others in your textbooks and literature. A protrusion or bulge of an organ or part of an organ through the body wall. Interesting, the word hernia has both a Greek and a Latin origin, and you can see that the translations for both would be appropriate and would apply to exactly what a hernia is. We're not going to talk about other hernias in other areas. Don't forget, hernia can apply to things. You can have a tentorial hernia, which is caused by raised intracranial pressure, an internal hernia, a paraesophageal hernia. So there are many different types of hernia in different sites. Hernia does have a long and interesting history. You can see from this graphic, this picture from medieval times, an attempt to reduce and operate on a hernia. And you can imagine the risks and problems that would arise in this situation. If you're more interested in the history of hernia surgery, which is of itself a really interesting subject, I point you to the Legends of Surgery podcast, and episode 20 discusses the history of inguinal hernia surgery in a really short and straightforward and really interesting podcast. So why are we discussing hernia? Well, it's very common. Up to 25% of males will develop a hernia, particularly in the groin area at some point in their life. And when I started looking into this, I was keen to see if there was anybody, any celebs, if you like, who had a hernia. Here's a website which lists hernias of the rich and famous. I didn't want to put any pictures up or name any names, but if you're interested in that, go to that website. I don't know why there's a shopping cart key. I don't think you have to pay to find out this information, but it just to emphasize that anyone can get a hernia. So just very basic anatomy to start with. Perhaps we'll start on the right-hand screen. So when we talk about ventral hernia, we mean at the front of the abdomen. So these herniae are here, dorsal being at the back, ventral at the front. So ventral and groin hernia are basically the two main anatomical distinctions that we're discussing today. I will discuss in a little bit more detail some of these specific hernias: epigastric, umbilical, spigelian, inguinal, femoral, incisional hernia. On the left, you can see a simplified diagram of the musculature of the anterior abdominal wall. The important points in the development of hernia, and the things that are clinically relevant, are, of course, the midline structures, the recti, the rectus abdominis muscles that fuse in the midline, and then the cylindrical muscles that surround the abdomen, the external and internal oblique, and the transversus abdominis muscle. The importance of this is that fusion in the midline and other areas can be areas of weakness and hence can give rise to hernia. There are also two in particular interesting aspects in the anterior abdominal wall. The arcuate line, which is, that's not quite in the right place actually. The arcuate line should be down here. And that's where the posterior leaf of the internal oblique and the transversus abdominis actually run and fuse anteriorly. So we just have transversalis fascia down here. And so that's kind of an inbuilt weakness or defect, which can predispose to certain types of hernia. The inferior epigastric artery and vein, which run posteriorly in the posterior abdominal wall, or sorry, the anterior abdominal wall, but posteriorly, if you like, posterior aspect, are important markers. And they are important surgical and clinical markers because they help distinguish the true anatomical differentiation of indirect and direct inguinal hernia. I'll come back to that. You'll see a picture of that, and it'll become a bit clear as we go on. So how can we classify these hernia or herniae? So by site, so we've said already, we can have ventral or anterior abdominal wall hernia, groin hernia, are by far and away the commonest hernia that you're going to see, that we're going to see, that we're going to assess and see at a clinic or operate on. There are really rare hernias that can occur within the pelvis and the flank, such as obturator hernia. We're not going to discuss those any further because they're just uncommon and just cloud your brain if you start to think about these. Stick to the common things. Let's learn about the common things. That's what's important. We can differentiate or classify by cause, so congenital versus acquired, and primary by or secondary. So before we come on to that, let's think about some of the clinical features in general that we could apply to basically all of these types of ventral and groin hernia. What do we want to know in the history? And what sort of questions do we ask? Well, hernias can be, of course, completely asymptomatic, and they often are. But when they can present with either a lump here, bulging, or a lump, or they can have pain and discomfort, or both. So with any history of pain, I'm not going to go over that again and how to take a history of pain, but the typical questions are, what's the type of pain? Is it dull, sharp, onset, site? When does it occur? Where does it occur? And associated features. If there's a lump or bulging, where's the bulge or lump? And very specifically, a very useful question is, does it appear on sitting, standing, lying down? And often it would be worth asking a more direct question, that is, does it disappear when you lie down? If you have a history of that, that's, even without touching the patient, you can almost say that they have a hernia. As always, we want to take a general history, and in particular, smoking and diabetes would be considered risk factors for the development of quite a few types of hernia. Occupation may or may not be a risk factor. There's really no clear consensus on that. It may be that just once you develop a hernia, your occupation with repeated straining and stress over time may make your hernia more symptomatic and therefore present earlier. It's probably more likely the case. But it's worth asking, what's your occupation? Because it'll have an effect on your ability to undertake your work and recovery from hernia surgery. The general principles of examination are that you must examine the patient both standing and lying. You want to assess, is the hernia reducible? Does it go down? Can you push it in easily, with difficulty, or not at all? In the more acute situation, we want to know, is the hernia tender? Look at the overlying skin. Is there discoloration? Is there redness? And for reasons that we'll show in a second, we clearly want to know what the bowel signs are. So beware a hernia, because it can be silent until it causes problems, and they can be very big problems, namely obstruction or incarceration. That means the hernia is stuck to the hernia sac and you can't reduce it. So incarceration, irreducibility, bowel obstruction. And this is a particular risk with femoral hernia and also these rarer hernias in the pelvis, such as obturator and sciatic hernia. When we examine the patient, we want to examine the abdomen fully. So the classic mistake to make is in a patient with a bowel obstruction and all the features of small bowel obstruction, high-pitched bowel sounds, cramping, abdominal pain, vomiting, constipation, and to miss an incarcerated or obstructed femoral or inguinal hernia. And that's why we teach the importance of exposing the groins and looking at the inguinal area as part of the general abdominal examination. That's the reason for it. In the old days, we used to say from exposure from the nipples to the knees, we wouldn't do that at the bedside, but as part of the abdominal examination, we must include an inspection and palpation of the groin area to rule out hernia. So back to the risks, the lying in the grass and how things can develop. So these are the important dangers with hernia. They can become incarcerated. That means material is stuck within the hernia sac. That can be bowel, that can be omentum. But with bowel, the problem is that if the neck of the sac becomes tight enough to compress the venous return, then you've got arterial flow in, reduced venous return, and then swelling develops. And as that swelling develops, we're into a vicious circle of swelling, a further reduced venous flow, and then eventually so much swelling that it impairs the arterial supply, and then we have strangulation and necrosis. So that's what strangulation is. The bowel can be twisted, but it's likely to be due to compression at the neck of the hernia. So incarceration, stuck, obstruction of the bowel, and then ultimately strangulation and necrosis. Important type of hernia is really just an anatomical variant, which is a Richter hernia, where you can have a segment of the bowel within the sac, and so the antemesenteric border of the bowel becomes necrotic, but yet the remainder of the bowel is normal. So you can have this hernia without evidence of obstruction, but a dangerous, potentially dangerous situation with a hernia which is got dead bowel wall and risk of perforation. So going back to thinking about causes, primary versus secondary hernia. Primary is either congenital or acquired, and in most cases and most hernias, this is, for instance, in the groin area, this is what we'll see. It's acquired due to fibromuscular weakening. Why that happens, we're not really sure. It may well be a genetic predisposition to that, and if we have a hernia in the groin region, we may well already have an inbuilt defect or weakness in the anatomy of the inguinal canal or femoral region that predisposes us to this. It's thought that maybe that's why smoking might and diabetes might be additional risk factors, because it can affect collagen cross-linking, and that might be a factor as well. When I talk about secondary hernia, we mean incisional hernia and peristomal hernia. Okay, so if there's been a wound in the anterior abdomen, that will always predispose to the development of a hernia. So for acquired hernia, we suggest that there's a weakness in the muscles and the fascia. Again, these are risk factors that would be associated with that. We've added in obesity and pregnancy now to our list. Importance of without getting too involved in the law of Laplace, which seems to crop up a lot in surgery. But the principle is that the wall tension is related to the pressure, which is, if you like, this is the abdomen, this is the hernia, and because the radius of the hernia is greater, the tension is increased. The wall is thinner, the tension is increased. So once the hernia develops, it means that over time, the hernia, it will not go away, and it may well increase in time, and that's because of this law of Laplace. So let's quickly mention these ventral hernia: epigastric ventral, paraumbilical, and Spigelian hernia. Epigastric hernia. they're not uncommon. They generally, it's defined as a hernia between the siphisternum and the umbilicus, but they're generally high up near the siphisternum, always in the midline, twice as common in males and females. They usually contain a little bit of fat or mental tissue, and we usually would fix them, and that's usually done as a simple procedure with suture mesh material. Paraumbilical hernia is really quite common, which gives rise to this appearance around the umbilicus. These are the risk factors, commoner in females and males, and we would generally fix those if they were giving rise to symptoms. We're not going to talk about congenital umbilical hernia today, but these herniae in babies or neonates usually resolve spontaneously. Spigelian hernia are rare, as you can see, and will tend to occur in this region here, and can give rise to obstruction and problems, and usually need repair, either open or laparoscopically. So the secondary hernia we've mentioned are incisional and peristomal hernia. So any wound in the abdomen would predispose to the development of a incisional hernia. Here, multiple wounds, and here we can see a stoma, likely an ileostomy with the spout, and we can see a bulge around that, and that is a peristomal hernia, and you can see the midline scar. They're really common. Midline wounds have by far and away the highest risk of development of these hernia. A good question for OSCEs and a good question for postgraduate exams are risk factors and factors that predispose to incisional peristomal hernia. And you can divide that, if you're doing it systematically, into patient factors, technical factors, and the type of surgery. I haven't time to go into that, all of that now, but patient factors could be, again, inherent things like diabetes, immunosuppression, on steroids, COPD, and so on. So in your own time, you could maybe look into that a little bit further. So let's talk about groin hernia in broad terms. By this we mean inguinal versus femoral hernia. The main anatomical differentiation is that we have the inguinal ligament that attaches to the pubic tubercle here, and the femoral hernia comes through the femoral canal, so navy, nerve, artery, vein, Y fronts, and the femoral canal is there to allow the femoral vein to expand and reduce in size, so it's an inbuilt weakness or defect. A inguinal hernia comes through the inguinal canal. Now, this is an indirect hernia. I'll just discuss this in a little bit more detail in a second, but a hernia that comes through here is an inguinal hernia, so above the inguinal ligament. And typically on examination, we differentiate the two by saying that a femoral hernia is below and lateral to the pubic tubercle, and an inguinal hernia is above and medial. So you can see that's why we say above and medial. If we start with the external oblique and the inguinal canal, we open it up like a book. We're looking at the back of the inguinal canal opened up, and we have the spermatic cord, or the round ligament of the uterus in females, or the contents of the inguinal canal. And here again are these important inferior epigastric vessels. So an indirect hernia comes lateral, around, indirectly, around and down. A direct inguinal hernia comes directly through here, direct through the posterior abdominal wall. And it comes through this area we call Hasselbalch's triangle, okay? Inferior epigastric vessels, rectus abdominis, inguinal ligament, inguinal canal. Again, inferior epigastrics, indirect inguinal, lateral, direct inguinal, medial. I hope that's clear. It can often cause confusion on examination. Again, it may be something that we've dealt with in another talk in a bit more detail, whether it's important to whether you even can clinically differentiate. I'm not really sure that you can, and there's evidence that you can't really truly differentiate direct and indirect inguinal hernia accurately, but there are sort of clinical tests for doing that. One important thing is that with indirect inguinal hernia, the big thing with indirect inguinal hernia is it can extend in males into the scrotum. If the hernia extends into the scrotum, then by definition, it is indirect. And the classic clinical examination is, can I get above it? In other words, can I pinch my fingers above a swelling here? If I can't, then it's coming from way up here, and that has to be an indirect inguinal hernia. So again, that would be another talk on causes of scrotal swellings. Femoral hernia, we can see, we've mentioned already, comes through here, medial to the femoral vein. Symptoms and signs, again, as we mentioned, the principles at the start of the talk: age, cough, ask about smoking history, family history, obesity, and indeed previous surgery would be important. Again, the emphasis on landing and standing examination, and whether there's both a visible and a palpable cough impulse. Get the patient to cough, have a look, can you see it? Then put your hand to the area, and can you feel that cough impulse? I'm going to fry your heads with these figures, and in fact I'm not. I'm going to just quickly go through this. But I think the important thing is to say that inguinal hernia is commoner than femoral by a long way, but if you have a femoral hernia, 40% of them will present urgently. So they're more likely to need urgent treatment. If you have a femoral hernia, it's more likely than females that you would need a repair. But remember, here's the figure, the important figure: inguinal are by far and away more common than femoral hernia. Treatment: inguinal, yes, usually. There are occasions where you can do watchful waiting, but if you remember these figures, if you do that and observe the patient, about 30% at 3 years will need a procedure because of symptoms, and about 70% at 7 years. For femoral hernia, basically, we would recommend usually treatment. A few words just to remember, just to remind you: herniotomy is division of the hernia sac, and that's only something that you do in pediatric surgery. Herniorrhaphy, orrhaphy is repair, or herniaplasty, repair with a mesh. Generally, we would say herniorrhaphy. Come to the end now. Just very briefly, the techniques, just to make you aware more than anything. Very commonly, open repair is done with a mesh, which we call this a tension-free or a Liechtenstein repair, and it's probably the gold standard repair nowadays. It's got good results and low rates of recurrence. Sometimes we still do a thing called a Shoedice repair. If you listen to the podcast, it'll mention that. That's quite interesting technique. And of course, laparoscopic repair. There are several techniques of laparoscopic repair which also have advantages and disadvantages over open mesh repair. So to finish off, to summarize everybody, we've discussed classification of hernia and hernia anatomy. We've talked principally about ventral or anterior abdominal wall hernia and groin hernia. Primary and secondary hernia. We talked briefly about what the important complications are, namely incarceration, obstruction, and strangulation, and briefly indication for treatment and some types of treatment. And that is it. Thank you.
Excellent, Colin. We have some questions. Can you clarify again regarding what the difference between an irreducible, an incarcerated, and a strangulated hernia?
Okay, so irreducible means that the hernia is out, it is stuck, and you cannot push it back. So in normal hernia examination, as I said towards the end, you've got a visible and a palpable cough impulse. You'll see a hernia or a lump or swelling. You would be able to push that hernia back. If a patient was lying down and they had a hernia, gentle pressure, that hernia will eventually go back into the abdomen. So that's reducible. Irreducible, it's stuck. That's not going to happen. And that can be because of the contents of the hernia, omentum, bowel, whatever, are stuck there. Incarcerated means that there's something stuck within the sac. Usually that will mean fatty tissue or a mental tissue, but that hernia will in itself be irreducible. So irreducible, so it's kind of a, if you like, a Venn diagram of incarceration and then irreducible. And then finally, obstructed applies to the fact that bowel itself is within the hernia. Nearly always that will be small bowel, and that bowel will be, if you like, pinched by the hernia neck, the neck of the hernia, causing basically a mechanical bowel obstruction. So,
with that regard, Colin, we've got another one saying, does strangulation refer to venous drainage impairment?
Well, strangulation just basically means dead bowel. Well, I suppose the ultimate phrase is necrosis, but if we, impaired venous return is part of the pathophysiology of strangulation. So strangulation means that the blood supply, the venous return is impaired enough to cause compromise of the blood supply to the bowel. Now, the bowel, when you operate on on a strangulated bowel and on a hernia, when you release the bowel from the hernia, it may recover. The blood flow may return enough to the bowel to make it viable. But at the time of surgery, it's pretty obvious. The bowel will be a dusky blue, cyanotic color, which in time will progress to black or necrosis.
Okay, we've got several other questions that are asking about prevention of hernias in midline wounds.
So that's a big topic for another day, I think.
I know. We've got lots of management questions, lots and lots of management questions. I think we need to a specific webinar about management. But,
I think, yeah, because I think when we discussed what this webinar would be, it was kind of to start the whole, generate an interest and start with a broad brushstroke of hernia, and I think I just wanted to kind of make everybody have a sort of an idea of the principal main hernias that you would see on a day-to-day basis, on a clinical basis. And I think in time, I agree, Cynthia, that we would need to spend a bit more time and more detail talking about inguinal or groin hernia and incisional hernia, these secondary hernia, incisional hernia, peristomal hernia, because that's an important topic. It's something that surgeons who do abdominal surgery will be more than familiar with, as you know. One of my mentors used to say the three causes of an incisional hernia were poor technique, and poor technique. I'm sure you've heard that.
Yeah.
But anyway, not to be facetious about it, but it is important. It goes back to what I said in talk. There are risk factors, and technique is one of them. But medication, patient factors, there are multiple factors that can predispose to the development of incisional and peristomal hernia.
Excellent. I think, Colin, if you're okay, we can leave it there. It's gone 4:30.
Okay.
I remind everybody that the next webinar is going to be on the 26th of May. It's going to be about perianal fistulae, and it's going to be